Awesome. Okay, well, quick introduction. Thank you everyone for joining. A little bit hectic at this end, but just another day at the Heart Center. So I have today, the topic is LVAD therapy in New Brunswick. Is this a bridge to improved survival? And this is a talk that both JF and Chris kind of wanted to present, even though we're not at the point yet where we have a VAD program in New Brunswick, but at the same time, we are really moving forward with respect to mechanical circulatory support and assist devices. And as we grow the program, I think one of the things we need to seriously consider is VAD therapy in New Brunswick for people with advanced chronic heart failure. So with that in mind, both JF and Chris are going to present on this subject. Thanks, guys.
Yeah, thank you. So Chris and I are going to share a little bit of talk, and hopefully I can provide a little bit of vision and thoughts around that. So obviously advanced heart failure or heart failure, whoops, if I can move the slide. Sorry, computer is in slow mode. So heart failure affects many patients and obviously is affecting Canadians, and New Brunswick is no different, particularly considering the burden of disease in the province. But understanding the course of disease of heart failure is often complicated. And this slide is just to illustrate how heart failure is often characterized by recurrent decompensation. So patients presents initially, is put on appropriate medical therapy, does well for a period of time, but then as a series of decompensation. And the hard part clinically is when are we too late and when can we intervene in these patients to try to bring them back before they obviously get to the point of pump failure and no return. And that's obviously where clinical acumen and certain high-risk features are particularly important, and where certain advanced therapies should be considered. And this hopefully it will come back to a bit later. I think we sometimes forget, and this is old data from the Intrepid trial, which was one of the trials comparing optimal medical therapy to mechanical circulatory support from the early 2000s, looking at advanced heart failure. So these are patients that are inotrope dependent or have been on inotrope as treatment. You know, their 1-year survival is very poor and their 2-year survival is very, so this is a very deadly disease. And these are the patients we're talking about. We're not talking about all heart failure per se, but what about advanced heart failure patients? And sometimes we don't think of advanced heart failure as a terminal illness, but it really is. The 1-year mortality in advanced class 4 congestive heart failure on optimal medical therapy can be as high as 70%, and is not that different than pancreatic cancer or stage 4 lung cancer from non-small cell. So again, a very, very high mortality burden for these patients. And this is where certain therapies like mechanical support potentially should be considered. So hopefully today I'll convince you that, you know, I think we have a clinical need, and heart failure management is evolving, and we need to be aware of this evolution. I don't want to go in the optimal medical therapy side of things, because that has also evolved tremendously, and my colleagues who take care of these patients do an amazing job in these patients in terms of prolonging their survival and their quality of life, and that's really important. But there is a subset of patients that I think would fit eligibility for advanced therapies, and this is really what I want to focus on, and what kind of vision for the New Brunswick Heart Centre as we go forward. And part of this vision includes education and talking about this, which is what we're doing today. So I thought I would start with a case. This is a particular case. If I can get that film to play. Oh, maybe it will not work. But anyways, not that important. I wanted to illustrate that this gentleman, he's a gentleman I saw in consultation last year, 64-year-old gentleman, cardiomyopathy in 2004, so a long history of heart failure, ICD in 2012, on good medical therapy, in reasonable shape otherwise, no end organ problem, but really was starting to have worsening symptoms with both rhythms, so some non-sustained VT that was being treated and significant mitral insufficiency. And I was asked to see him from mitral clip point of view. The clip that I wanted to show you here was just to illustrate how that EF looked in the teens, and really the mitral insufficiency was just a marker for me of a pump failure, and that fixing that mitral insufficiency was not going to change the course for that patient. And so that patient, of course, in hospital, so I thought he was not a candidate for mitral clip, but I thought he should be considered for advanced therapies, and some of these advanced therapies do include CRT, device upgrade, but also evaluation for mechanical support. But unfortunately, post this CRT device, developed VT storm and ongoing CPR in the cath lab and Lucas to provide that CPR. So clearly that patient went quite rapidly into an extremis phase. So what are the consideration and the options for patients for mechanical support in that scenario? And this is the kind of scenario that sometimes we get faced. And these are the kinds of things we think about when I get called for that. First of all, is this a reversible cause? So if this was his first presentation with heart failure or an ischemic event, you have potentially reversible things. But this gentleman is a 20-year history or 15-year history of heart failure. He's very unlikely to recover from that from a heart failure point of view. This is the natural history of decompensation. Is there an exit strategy? Well, exit strategy, what I mean by that is that if a patient is very unlikely to recover, are there other options if he's not going to recover? So this gentleman, would he have been a transplant candidate otherwise? Would he be a candidate for mechanical support? And then lastly, are there comorbidities or end organ issues that would potentially affect their survival, sort of, pulmonary fibrosis or dialysis dependent renal failure? Those are the kind of things that affect survival in these patients that you may not want to consider bridging, because they will make that likelihood very, very low. So the kinds of things I'm thinking about when you see them in that setting is really, do we need left and right support? Obviously, if you're doing CPR, it's a biventricular failure. You likely need support for both left and right. Am I too late in doing this? We're called immediately. They're doing CPR. They're doing the best they can to resuscitate him. It was witnessed. Is this feasible? So from a technical point of view, can we actually provide support? And what's the likelihood of support of survival in that patient? And this brings me to, now that we've talked a little bit about the case, just a little bit of thinking around, how do we think of advanced heart failure? And I think this is important from a vocabulary point of view. We're all used to the New York Heart Association Class 3, but then the advanced Class 3 to 4 and Class 4 is these patients. And this is where Intermax classification is very helpful. And what I mean by Intermax classification is we think of Intermax from Class 1 to Class 7 in advanced heart failure, and Class 1 being the cardiogenic shock patient. Class 2 is a progressive decline kind of patients, which despite medical therapy, including inotrope support, they continue to decline with renal function and poor blood pressure, for example, that kind of stuff. The Class 3 would be an inotrope dependent patient, but that can be mobile. And Class 4 would be a recurrent decompensation or admissions to hospital, for example. So essentially that Intermax 1 to 7 is really the kind of thing that that is helpful in assessing patient for mechanical circulatory support. I'm going to ask Ansar if you could talk to Dave Buick, because he's he's trying to call me, I think, about that patient we talked about this morning. Just to make things more complicated, if you don't mind. Anyways, the Intermax classification here is very important in assessing these patients. Obviously, the cardiogenic shock patient requires action within hours, while the patients in recurrent decompensation is relatively elective, potentially weeks and months to decide. Another way to think about this is, again, the same way, the classification, but what are the patients that would benefit for mechanical support? Clearly, Intermax 1 and multi-organ failure are not LVAD candidate patients. These are patients that you need some support of some sort, potentially, to bring them to a decision whether or not you can salvage those end organ problem and salvage their life to maybe make them an LVAD candidate. And this is where it's very important. So putting LVADs in patients with these types of decompensation are unlikely to survive, and the benefit of the device is not there. But in the Intermax 2 and above, there's certainly, from 2 to 4, this is where the VAD benefit is established and the evidence is there. From the 5 to 7, not yet established. And this is where it's evolving in terms of therapy. So this gentleman went on, and I'll pass on to Chris. Maybe Chris can tell me where to increase the slide or to change the slide as we go forward.
Perfect. Thanks, Jeff. So we got called again, just to reiterate, with this patient who is in the EP suite in the midst of an ablation, who now has VT incessantly. has a Lucas on that has been getting CPR for about 15 minutes, and they've not been able to get him out. And because JF had seen him already, and we kind of knew his backstory a little bit, we felt that he likely would hopefully have an exit strategy, that being a durable VAD, albeit a bit of a long shot at his age. And he was, pretty far down the advanced heart failure road already, in terms of cachexia and malnourishment. But we put him on ECMO in the EP suite with CPR ongoing. This is just a schematic of, arterial cannula and femoral artery, and distal perfusion catheter in his SFA, and a big venous catheter going up in his IVC, which you can see at the bottom of his X-ray, that multi-stage catheter in his IVC. So he went to Jay, if you could advance the slide. He went on to the SICU, where we recovered his end organs, got his vasoactive drugs down. A kind of brief neuro exam demonstrated that he, was moving all 4 extremities and appeared to be neurologically intact. At which point we, discussed with Halifax whether they would consider him for a durable VAD. So he was transported to Halifax on VA ECMO support. In these kind of patients where, he's pretty deconditioned, pretty advanced heart failure, has just had CPR and an ECMO run, your best option is a bridge-to-bridge strategy. So he had a central temporary LVAD implanted, which allows you to get these patients up, walking around and rehabbing, to see whether you can get them good enough for the investment of a durable VAD. So he was on a short-term central temporary VAD for months to get him to the point where he was rehabbed enough to get a durable VAD, and he ended up getting a Heartware HVAD in September, and then eventually discharged home in January. And I think his overall course really exemplifies how getting these patients much earlier than this patient was is key to a good durable VAD outcome. When you have someone that is that as far down the advanced heart failure pathway as he was, and then let alone once he's had CPR and an ECMO run, you can see how difficult it is to get someone like this home, and months and months, 6 months in hospital. But he amazingly did survive and was discharged home on his HVAD. Next slide, Jeff. So I just wanted to give you a little bit of an update on current VAD outcomes to see where we are in the advanced heart failure world. So the newest pump on the market is the HeartMate 3. And this has the newest data, which is why, I think it's worth discussing. This is a fully magnetically levitated pump. And it has a multiple factors that have really eliminated the problem of pump thrombosis, and made these pumps more hemocompatible. So JF, if you could go to the next slide. This is a slide demonstrating the improvements in survival as the VAD technology has improved. So you can see that first yellow line at the bottom is the initial medical therapy for advanced heart failure patients that JF showed at the beginning of the presentation. So 1 year survival in the 10-15% range. And you can see as you move up over the last 20 years, as the VAD technology has improved, we get to a point where now our 2-year survival is in the 83% range. That's based on the Momentum trial, which is the HeartMate 3 versus HeartMate 2 trial published in 2018. So you can see the dramatic change in outcomes in these patients. Next slide. And actually, with even more kind of current multi-center data looking just at HeartMate 3 data, you can see the pink line is HeartMate 3 survival, and the yellow line is heart transplant survival. Now, these pumps cannot compete with the long-term outcomes of transplant at this stage, but you can see how at least the early outcomes are now on par with heart transplantation. And I would imagine as technology improves, at some point, the technology will be able to compete with heart transplantation. Next slide. So if you remember this slide from earlier in the talk, you had a diagnosis associated with a 70, 80% 1-year mortality that now has a 1-year mortality in the 10% range versus 80%. And, you know, there are few therapies in medicine that can dramatically impact survival like this technology, especially when you compare this to other, you know, end stage cancers where chemotherapy drugs are improving survival in the, you know, 10% range, not 70% range. This is not just survival, but also quality of life. You can see in that from an NYHA functional class perspective, 6 months post-VAD implant, you know, you have 90% of people in the NYHA class 1 or 2 range versus everyone in the class 3B and 4 range preoperatively. Next slide. So this is, you know, the next question always comes, well, what does this therapy cost? If you could advance the, yeah, so, you know, just as a comparator, transplant is, you know, in the $80,000-$90,000 range per quality adjusted life year gained. The initial DT-VAD trial with the first generation pulsatile pumps, you can clearly see was far beyond what is considered cost effective. But as these trials have progressed, the technology's improved, the outcomes have improved. You know, the HeartMate 2 data, HVAD data suggested cost per quality adjusted life year gained in the $125,000 range. And with the elimination of pump thrombosis, decreased rates of stroke and readmissions in the HeartMate 3 era, this is projected to be less than $100,000. Which now becomes the range where this is, you know, really an effective therapy. I think we're now shifting back to you, Jeff.
Yeah, I'm just going to skip a little bit faster since we're approaching a little bit our time, but certainly the Canadian Society for Heart Failure certainly has recommendations on acute, severe, or chronic advanced heart failure in which patients you have an appropriate life expectancy to consider advanced therapies. So this is clearly entering our world in terms of treatment. And so the CCS would suggest that these are the kinds of patients for consideration for advanced therapies. Obviously, low EF patient with poor VO2 max, so less than 50% predicted. But really the kinds of risk factors you're looking for are patients that are intolerant to goal-directed medical therapy, for example, with worsening renal function, hypotension, recurrent hospital admission, inotrope dependence, difficulty with activity of daily living, volume overload, refractory to diuresis. And this is often the problem that we run into as we wait for a long time is worsening right heart failure secondary to pulmonary hypertension. Unfortunately, that is one of the, if we wait long enough to the point where we have right heart failure issues, that may have been the point where we passed the potential benefit for LVAD support, because LVAD is really a left-sided therapy. But there is a sweet spot in which we can help patients try to prevent these complications over time. So hopefully I can really bring back to the start of the consideration is really, we're trying to think beyond bridge to transplantation. That's what I mean by the BTT. You know, we should think of patients that are younger than 70 without significant organ problem, recurrent admission to hospital, and high risk features, which I've mentioned. So the worsening functional MR, which we saw in that patient I presented also had VT burden and was not improving on optimal medical therapy. So he had all of these things. So he was clearly somewhere along the line, and he forced us somewhere, obviously quickly, that might not have been entirely predicted, but looking back, obviously, and obviously the goal is to intervene before frail patients become frail from their end organ problem with heart failure. So where are we and how are we doing in New Brunswick? Well, the clinical gap is the estimation in Canada is around 20 to 40 durable VAD or durable MCS per year is what is predicted in large provinces like Ontario, if you look at Ontario numbers or Quebec. And so how that would mean for us, you know, around 20 to 30 patients potentially in New Brunswick. We are currently in the last 10 years, I've had 35 patients go to Halifax for treatment, and I know of more than 10 in the last 10 years to Quebec. So that's likely referring about 5 to 8 per year in New Brunswick. So there are potentially patients that are not seeing this therapy for a variety of reasons and barriers or late in coming to be seen. So clearly, we do have a gap. We are evolving and potentially this is obviously going to be something we're hoping to do better with going forward. So hopefully I've been able to convince you that there's a clinical need. I think at the Heart Centre, we have the expertise. I think the treatment are evolving and becoming cost effective. And really we're at the phase now of program building. And what I mean by program building is obviously going to mean education, collaboration, partnership, and lots of things in place. But this is how I sort of see things are currently moving at the Heart Centre. I'll take one more minute before Ansar shuts me down. So advanced heart failure presentation, in the acute setting in our CCU, we reviewed the last year of shock data. 8% of our admissions had some form of Class C shock, which is classic shock or more. Optimal medical therapy, including PCI heart surgery, is something we've been doing for a long time. We've obviously selected some patients to benefit from short-term mechanical circular support. Most of the patients we aim for recovery, but there are patients that we aim obviously for durable VADs, and we obviously send these patients currently to Nova Scotia, but this is a very difficult endeavor for a multitude of reasons as we go forward. But there are also the chronic heart failure presentation, and these are the patients we just talked about. How many of those fit in the durable VAD population? And this is something that over time, I hope we set up the processes in place that we can see these patients a bit better. We have a new heart failure cardiologist starting here this July, or August, I should say, which will really help us in building that program as we go forward in the future and addressing resource needs and all of the things that are needed for that. Anyways, I'll stop that. And thank you very much, everybody.
Thanks, JF and Chris. That was excellent, actually. And I feel like you might have felt rushed, but at the end of the day, I think you kind of covered the topic nicely. And two things from my standpoint, and obviously I'll open it up to any other questions, and feel free to include it in the chat forum or even just unmute yourself. So number one, I think, is the fact that it's clear that even in the setting of chronic heart failure, much like in the setting of acute heart failure, mechanical circulatory support is something we should probably be thinking of earlier as opposed to later, is the impression I'm getting. That sort of the patient who's coming in, with advanced heart failure, an EF of 10% with severe MR, we shouldn't be trying to think of how to fix the mitral valve in the hopes of getting them through. Rather, we should be thinking about mechanical circulatory support in the form of a durable VAD. So that's my first question. Is that kind of the right line of thinking? Is that the paradigm shift that we need to make here in New Brunswick?
Yeah, I mean, I think there'll always be room for, standard therapy for many things, but, like the patient I presented, I really did not think the MR was a problem for his decompensation. He was just a sick heart, and a sick heart, I think in that setting on optimal medical therapy, as good as we can offer, we're just putting Band-Aids to try to fix the MR and those kinds of things. And he was young enough and well enough that he had the option of potentially even heart transplant. We were lucky a little bit in how we managed to get him through. And I would hate for us to be always in that scenario. Oh, we're going to try this, and then they're going to decompensate. We're going to go short-term VAD and all of that. But I think you're right. We need to sort of shift sometimes. And we have those, in the last 2 years, we've had many more of these conversations at our Wednesday rounds than we've had in the past. And something that we're sort of, gradually shifting our mindset to, these are patients we might consider different options, for sure. I'm sure Chris would have
Yeah, I would echo that, and really the data supports that. When you look at outcomes after a durable VAD, when you were bridged with another technology to that durable VAD, so either a short-term central VAD or ECMO, the short and long-term outcomes are significantly worse. So you want to be able to get to these people before they're in an acute shock state, before they're in a max 1. You want these people at, ideally in max 3 and 4, where your end organs have recovered, you've been able to diurese them, you've been able to kind of optimize them as best you're able on inotropes or intensive inpatient medical therapy, and go straight to a durable VAD from there. As soon as you're on short-term support, it's a much more difficult battle to win. And so I think as Jeff really has highlighted, it's about identifying these patients early. Even if they're too early, then you can just intensify their follow-up, get them referred and evaluated, and then really decide together with the patient, with the referring cardiologist, with the heart failure cardiologist, when the right time to intervene is. And everyone's going to be different in how quickly they progress to that point. But I think I think Amy Noel and advancing our heart failure cardiology program beyond what is already a good program here will also help that, having kind of a centralized referral process to evaluate these people.
And
I guess
I think we'd benefit also from multidisciplinary aspect to all of this. So when we evaluate patients and make decisions as a, not just as a one person decision. So really try to gain experience from everybody, whether it's CRT from an EP point of view, the clinical cardiology perspective, the interventional guys. So everybody together, I think we can provide some input here.
Well, what's interesting is that, we evolved from having, our standard Wednesday morning rounds to having TAVI rounds in addition to MitraClip rounds to aortic rounds. And, eventually we're going to be at heart failure rounds, and it may involve all of the above. I have an uncle in Atlanta right now who, had a previous CABG, then had a minimally invasive mitral repair, is now in heart failure. And, all the thoughts that are going down there include MitraClip, transcatheter mitral valve replacement, CRT plus, he's 80, so he's not really a durable VAD candidate. But having said that, I mean, there's just so much more on the horizon now as compared to even 10 years ago. The other question I would have, and once again, I would encourage anyone, if they have questions, to step forward. What would your comment be, I guess thinking from the standpoint, if I was the administration and I was saying, well, we've only ever kind of referred 5 to 8 patients per year on average for VAD therapy, in sort of in the spirit of the hub and spoke model, why aren't we kind of still having Halifax be, the hub, and we can just continue to be the spoke? Why do we need to be the hub for durable VAD therapy? And when they can do all of the above. So I would ask both of you that. I mean, you obviously, JF, because you come from the Halifax system, and then Chris, because of your experience at Duke and Edmonton.
Yeah, I'd comment on two aspects. One is the 5 to 8 per year is actually a good volume because Halifax, the biggest year they've done was 15, for example. So just to give you an idea, sort of the 8 to 15. So from an expertise point of view, I think it's a reasonable number. I think from a practical point of view, our difficulty here is really we make clinical decisions, and then we hope that clinical decisions includes that therapy, but we need to convince another group of physicians that that's the appropriate therapy that we're making. So we're always a secondary aspect of that decision. So for example, that gentleman, we needed to sell very hard that patient on ECMO to send them to Halifax. And not that it's inappropriate for them to do that, but it sounds like a simple barrier to package somebody in an ambulance and transport them on ECMO to Halifax, but it is a Herculean effort. And I cannot overemphasize that aspect. It is unbelievable that gentleman, we managed to do it, and he survived that. And we've done several in the last year. So I think if we can internalize a little more of these decisions that make New Brunswick decisions, New Brunswick made solutions for our patients and the family and everyone, I think we'll serve better our population. And we're already expending the money because New Brunswick pays for that care in Nova Scotia and pays for that care in Quebec. So it's not a cost issue.
Yeah. Chris, final comment. Thank you.
Yeah, and I would echo what JF has said. And I think also, if just from a family perspective, especially in the COVID era, but it's difficult. These are long hospital stays. These are sick patients, and it's tough to be transporting to another province, during this process, and the follow-up being in another province. And, these people are readmitted. They have to end up, partially managed here and then transferred there. And, I think it's tough on families to be having that back and forth. And so I think it would be nice for, to really provide great patient care in our province. I agree with JF. I think the volume that we would see in the province is reasonable. There, Winnipeg is another hub and spoke VAD program that refers their transplants to, by and large part, to Edmonton and Ottawa. Like, these are, this is the hub and spoke model to include durable VAD therapy is been done in Canada and is currently being done in Canada and other provinces. So I think it's reasonable to go down that road, and we would continue to have a good working relationship with Halifax, because the line between who ends up being a bridge transplant versus destination therapy is always moving. And I think we would continue to foster a good relationship with the program there in terms of who should be evaluated there initially, who we would keep and consider implanting, and back and forth. So this would not be that we would not involve them. This would be a collaborative effort together with the Halifax program.
That's awesome. Colin, did you have a comment?
Yeah, just one quick question for the people who, from a technical aspect, how difficult is it to implant these devices for people like us who really don't understand the technical aspects of it?
Yeah, I mean, it's a median sternotomy. Well, for the most part, the HVAD really has advanced some minimally invasive techniques to the implant, but in general, it's you put them on cardiopulmonary bypass, you make a big hole in the LV apex, you sew the sewing cuff on, the pump goes into that sewing cuff, and then the outflow graft is sewn to the ascending aorta. So this is on pump beating, unless you're doing intracardiac work. So the technical aspects of the pump implantation, there's some fine details to it, but in general is not a long procedure if they're primary sternotomy. The art of it, the biggest part that takes the training, expertise, experience is in patient selection preoperatively, perioperative management postoperatively, and then the long-term management after the implantation. I mean, these are lifetime patients that you really invest in. And I would say that is where the bigger part in terms of expertise comes.
Perfect. Guys, thank you so much. I think that's a great overview, and I think a nice launch to hopefully what will develop into a solid heart failure program, especially with the arrival of Amy, and obviously with your arrival, Chris, and your expertise, JF. Guys, thanks so much. Next week, we have Ismail El-Hamamsi from the Mount Sinai Center, who's going to talk to us about the Ross procedure, and specifically about whether or not we should be offering the Ross to all non-elderly patients with critical AS. So it should be an interesting talk and thought-provoking. All right, everyone, have a great day and good luck.
Thank you.